Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
Hi everyone, and welcome back to Ready, Set, GYO. As previously discussed, vulvar cancer is rare, accounting for only 0.3% of all cancer cases in the United States. The overwhelming majority of these are squamous cell carcinomas. Today, we're going to be discussing the even rarer subtypes of vulvovaginal melanoma, vaginal melanoma, and vulvar Paget's disease. It'll be one of our shorter episodes. Sydney, what are our learning objectives?
Our learning objectives are to recognize that vulvovaginal melanoma staging and treatment follows the NCCN guidelines for cutaneous melanoma, to review vaginal melanoma, which is a distinct entity with different staging and treatment considerations, and to review the diagnosis and treatment of invasive vulvar Paget's disease.
Let's get started. When a patient is referred to the office for an abnormal appealing vulvar or vaginal lesion, the importance of the physical exam cannot be overemphasized. Vulvovaginal melanomas are subdivided into cutaneous versus mucosal lesions, which are separate from primary vaginal melanomas. These have different staging systems and different pathways in the NCCN guidelines for evaluation and treatment. Hart's line is the delineator for determining which lesions are vulvar or cutaneous, or vulvovaginal and mucosal. To remind you of vulvar anatomy, Hart's line is the lateral border of the vestibule, the area between the labia minora and the hymen, where the non-keratinizing vaginal epithelium meets the keratinizing epithelium of the labia minora. Mucosal vulvovaginal melanoma is defined as a lesion that occurs on the vulva inside Hart's line.
The primary workup for vulvovaginal melanomas, both mucosal and cutaneous, include a history and physical, imaging, and full skin assessment. PET-CT is thought to be the most sensitive in diagnosing distant metastases. Similar to other melanomas, nodal basin ultrasound and brain MRI can be considered. It's important on your physical exam to note whether the lesion is resectable or not. Vulvovaginal melanoma is a distinct entity. As we accrue more information about vulvovaginal melanoma, we are learning that there are different molecular profiles and different treatment responses than in other melanoma sites. More to come later in this episode. Despite this, staging and systemic therapy recommendations for vulvovaginal melanomas are the same as the NCCN General Cutaneous Melanoma Guidelines. Interestingly, this is the result of a study published by the GOG in the 1990s, which determined that the AJCC TNM staging system was prognostically the most accurate staging system in vulvovaginal melanoma. We'll review the vaginal staging system and treatment recommendations later.
This vulvovaginal staging system is detailed, and you'll likely need to refer back to it when you see someone in the clinic. Briefly, the T refers to primary thickness of the lesion, N is the number of involved nodes, and M refers to sites of metastases. Less than or equal to 1 millimeter is T1 disease, and greater than 4 millimeters is T4 disease. Ulceration of the lesion upstages the T component. N0 refers to no regional metastases, and N3 is greater than or equal to 4 nodes that are involved. M0 corresponds to no distant mets, with M1, A through D, referring to distant metastases to the skin or soft tissue, lung, non-CNS visceral sites, and CNS disease, respectively. Simply, anyone with nodal involvement will be at least stage 3, and anyone with distant mets will be stage 4. Stage 1 versus 2 is determined by the depth of the primary tumor.
Treatment algorithms for vulvovaginal melanoma have a lot of variation and are less standardized than for other disease sites, largely because we do not have any randomized control trials firmly establishing the best course of action. The first treatment decision depends on the clinical stage of disease and whether the primary tumor is resectable. Partial vulvectomy with at least 1 centimeter margins and nodal assessment with sentinel lymph node biopsy should be performed for all stage 2 or greater tumors. Sentinel lymph node biopsy can be considered for stage 1B tumors. The risk of nodal involvement in stage 1B or greater tumors is more than 5%. Sentinel lymph node mapping for cutaneous melanomas was established by the MSLT1 and MSLT2 trials, published in 2014 and 2017, respectively. These trials included melanomas of all primary sites and did not present results specific to vulvovaginal melanomas. MSLT1 established the efficacy and safety of sentinel lymph node biopsy in cutaneous melanoma. MSLT2 determined that completion lymphadenectomy after a positive sentinel node biopsy did not improve outcomes compared to observation alone. In patients with clinical stage 3 disease, like suspected nodal involvement on exam or imaging, a partial vulvectomy with clear margins of at least 1 centimeter if feasible should be performed, followed by systemic therapy and/or radiation or observation. If any disease is unresectable, then systemic therapy with RT should be given.
For systemic treatment, we reference the NCCN cutaneous melanoma guidelines. Preferred Category 1 recommendations include combination immune checkpoint blockade with nivolumab and ipilimumab, or nivolumab and relatlimab. Monotherapy with pembrolizumab or nivolumab also carry Category 1 recommendations. Targeted therapy with dabrafenib trametinib also carries a Category 1 recommendation and FDA approval for tumors with BRAF V600E mutations based upon the NCI MATCH study published by Salama et al. In 2020.
That's what we have for vulvovaginal melanomas. Maya, what about primary vaginal melanomas? What are the diagnosis and treatment differences?
Vaginal melanomas are extremely rare, accounting for less than 10% of all primary vaginal cancers. The most common presenting site is the distal 1/3 of the vagina. These tumors are so rare that there's not actually an NCCN algorithm or a discussion about staging or management of these cancers. Vaginal melanoma is considered to have a different staging system, which is very simple and differs from cutaneous, which is the staging system we use for vulvovaginal melanomas, as discussed above. Stage 1 is clinically localized disease, Stage 2 is regional lymph node involvement, and Stage 3 is distant metastases. The staging system does not consider depth of invasion. Really, the staging system is not nearly as prognostic as in other disease sites, but a tumor size cutoff of 3 centimeters has been shown to be more prognostically important. So how do we manage these tumors, Sydney?
Like in vulvar melanomas, treatment decisions are based on assessment of resectability. If the lesion is resectable, a wide local excision versus partial vaginectomy with at least 1 centimeter margin should be performed. A sentinel lymph node biopsy can be considered if lymph nodes are clinically negative, although this does not improve survival. Grossly positive nodes should be resected. After excision, observation with or without brachytherapy, with or without EBRT, and with or without systemic therapy is reasonable. These are all options and should be tailored to the patient.
If the lesion is unresectable or there's residual disease after resection, a clinical trial is preferred. Primary radiation therapy and/or systemic therapy is also reasonable. Unfortunately, the prognosis is poor with a 5-year survival of 5 to 25%. Earlier, we mentioned that vulvovaginal melanomas have distinct molecular profiles compared to other cutaneous melanomas. Can you tell us more about that?
Yes, this is really interesting. Wilhite et al. Published a molecular analysis of 142 vulvovaginal melanomas and 3,823 cutaneous melanomas in 2024. In their analysis, 106 vulvar and 36 vaginal melanomas were included for a total of 142. They found that vulvovaginal melanomas have less BRAF and more KIT, ATRX, and SF3B1 mutations. Only 8.5% of the vulvovaginal melanomas had BRAF mutations, with only 64% of these being BRAF V600E mutations. Overall, immunogenicity was lower in vulvovaginal melanoma compared to cutaneous melanoma. 0% had high tumor mutational burden and 18% had PD-L1 positivity. This translated to worse clinical outcomes. They found that the median overall survival was shorter for patients with vulvovaginal melanomas treated with immune checkpoint inhibitors, with 17.6 months versus 38 months in cutaneous melanomas. That resulted in a hazard ratio of 1.67. The findings of this study supported prior publications which had shown worse response to immune checkpoint inhibitor therapy in the treatment of vulvovaginal melanomas compared to cutaneous melanomas. The takeaway of this study is that molecular profiling should be done on all vulvovaginal melanomas in order to guide choice of therapy, as these tumors don't respond as well to the traditional cutaneous melanoma therapies.
That's really interesting. I'll make sure to order molecular testing for any of my patients with vulvar or vaginal melanoma in the future. Let's transition to another rare subtype of vulvar cancer, invasive Paget's disease.
Let's. Vulvar Paget's disease is a form of intraepithelial adenocarcinoma. The most common presenting symptom is itching. On exam, the lesions are typically multifocal with an eczematous appearance similar to Paget's disease of the breast and can extend into the vagina. In up to 25% of patients, there will be an invasive adenocarcinoma in or beneath the surface lesion, although the rate varies in studies. And there's roughly the same chance of having a synchronous malignancy elsewhere in the body. In patients with vulvar Paget's, it's important to work them up for another malignancy with mammogram, colonoscopy, and consideration of evaluation of the urinary tract via cystoscopy and reproductive organs. Some providers even recommend a CT chest, abdomen, and pelvis.
Treatment of vulvar Paget's disease consists of wide local excision or vulvectomy with a recommended 2-centimeter margin. Radical excision is not required. The risk of recurrence after surgical resection of Paget's is 12 to 58% in reported series. Because of the multicentric nature of disease, recurrences often occur despite negative margins. Fluorescein mapping with use of Wood's lamp has been described as a method to improve mapping of lesions and delineate margins. In a case series of 8 patients, this technique identified Paget's beyond the visualized margin in 100% of patients. Mohs microsurgery has also been evaluated to decrease positive margins and improve recurrence rates.
Imiquimod has been described with efficacy and relative tolerability for the management of non-invasive vulvar Paget's disease, but local effects can be severe with inflammation, erosions, and a fever or flu-like syndrome. This may be an option for people who can't tolerate surgery or those with positive margins who can't have re-excision. Other described treatments include CO2 laser, cytotoxic therapy, and radiation. Patients previously treated for vulvar Paget's disease should have a yearly exam with a low threshold for biopsy. That's all we have for you today. Maya, do you want to start out with our takeaways?
Sure. Vulvovaginal melanoma is staged using the AJCC cutaneous melanoma staging system, while vaginal melanoma has a distinct, simplified staging system. Surgical resection is recommended if complete resection is deemed feasible. Systemic treatment recommendations for vulvovaginal and vaginal melanoma are drawn from cutaneous melanoma recommendations and rely heavily on targeted therapies. Vulvovaginal and vaginal melanomas have distinct molecular profiling from other cutaneous melanomas, and individualized treatment, if utilizing systemic therapies, should be considered.
Vulvar Paget's disease is a form of extramammary Paget's and is an intraepithelial adenocarcinoma. In up to 25% of patients, there may be an invasive adenocarcinoma in or beneath the surface lesion, and there's a similar chance of having a synchronous adenocarcinoma elsewhere in the body. Workup for other cancers is imperative in the treatment of vulvar Paget's. Treatment is with simple vulvectomy or wide local excision, where radical excision is not required, but wider margins of about 2 centimeters are recommended as the margins can be difficult to delineate clinically and relapse rate is high.
This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Jessica Parker Metter, faculty at Indiana University Health, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya signing off.